diopter in vertical dimension, or around 5 disc diopter in the horizontal dimension, peripapillary lesion involving the optic disc. Okay, so that is important actually. Okay.
Yes.
Yeah. Then you can just go to the B scan image.
Yes, sir.
So this is very characteristics, but one very interesting differential diagnosis of such a scan, no, which can be seen if we document a dropped IOL over the retinal surface.
Right, sir.
So if we do a B scan when the IOL is lying on the retinal surface, we'll typically get this kind of picture. Actually, there will be back shadowing as well as there will be hyper reflectivity at the margin. Okay.
Okay.
Fine.
Okay.
You can proceed. Yeah.
Dr. Abhijat, at this point of time, did you want to rule out any systemic associations considering your working diagnosis of sarcoid hemangioma and any other?
Yes, ma'am. So actually, I wanted to rule out many systemic things, and her whole immunocompetent status also, and whether her kidney functions were normal or her even vitamin D levels were normal or not. So there are some syndromes which can be associated with these with this condition, but again, but again, the age group was, it excluded that diagnosis in some manner.
Trying to think of more common routine uveitis investigations. You were saying granuloma. So what would you normally do for ruling out like a sarcoid or a TB granuloma? Like if you can make it clear to everyone.
So I would go for an entire TB panel test which are to be done, which would include a Montu test, an ELISA, and RT-PCR even. And a TB gold quantiferon test can also be done for that. And regarding sarcoid, I would like to do serum ACE levels, and I would do a lung X-ray or a CT scan to rule out the BHLO, which is the bilateral hilar lymphadenopathy.
Okay.
So coming on to the first differential diagnosis, which is choroidal melanoma. So in this condition, we generally see a pigmented lesion, which can be either amelemnotic or it can also be a dark brown one. And it presents with it also has some subretinal fluid along with it. So on doing the B scan investigation, we see some low to medium internal reflectivity with some vascular pulsations. And these are the signs of the A scan. And on doing the B scan, we observe a collar button or mushroom-shaped excavation of the underlying uveal tissue. In cases of a choroidal melanoma, on doing the fundus fluorescein angiography, a very peculiar or characteristic sign is seen, which is known as the double circulation. And the image here at the low bottom shows the double circulation, and it shows simultaneous fluorescence of the retinal and the choroidal vasculature. And also we see some patchy early hyperfluorescence, which is followed by a late staining. And OCT shows a choroidal tumor with overlying some subretinal fluid and intraretinal cystic spaces. So the next diagnosis, as I said, the next differential would be a choroidal hemangioma. And in cases of...
On the B scan of the melanoma, I mean, the spikes, would you like to say something about the spikes and the choroid?
Yes, sir. So the spikes are, they range from low to medium, and they typically have a pattern of M-shaped pattern.
What is angle kappa?
Okay, I need to go into details about that, sir.
Yeah, so the thing is, because of, the very regular structure, internal structure, the spikes progressively go down from the anterior surface to as you go within the tumor, and so you will get a planting angle, what is known as an angle kappa. Okay, in melanoma.
Right, sir.
Characteristic for, along with that, you'll have choroidal excavation where, at the base of the tumor, the choroid is excavated out because it is arising from the choroid.
Yes, sir. So coming on to the choroidal hemangioma, it shows a reddish orange lesion which has a ill-defined margin. So on doing the B scan, we see a high amplitude with broad-based spikes. And the lesion itself shows as a biconvex or a fusiform cross-sectional shape. And the internal brightness of this lesion is generally similar to the orbital fat. And ICGA shows a very peculiar sign where we can see that there's early hypersynescence, which is followed by a late washout phenomenon. And on doing the OCT, we again see a presence of subretinal fluid above the corresponding to the lesion, and there is some photoreceptor loss, and anterior tumor surface is hyporeflective in such case. The next differential would be a posterior scleritis. So when I said in the beginning that the patient had, painless blurring of vision. So in cases of posterior scleritis, the patient would present with moderate to severe dull aching pain, which on the basis of history and examination, our diagnosis would include that. So in cases of posterior scleritis, the patient presents with a dull yellowish elevated marks with presence of subretinal fluid. And also there is presence of vitreous cells in the vitreous cavity, and also plus or minus choroidal folds. So on doing the B scan, again a very characteristic sign which is known as the T sign is seen, which shows thickening of the posterior cords with presence of a retrobulbar edema. And on doing the OCT image, we see that there is choroidal thickening with optic disc edema might be there, and if it is there, it can be seen if the section is taken via the optic nerve. And there's presence of subretinal fluid also, and the RPE layer shows a blade-like changes pattern. The next would be a choroidal metastatic case, but it is quite unlikely in our patient as there is no systemic involvement at all in it. But since we are talking about choroidal lesions, so I included this one also just for the purpose of discussing it. So the primary important thing is to have choroidal metastasis. It is a must that there should be some systemic involvement. That means there should be a primary site of carcinoma. So on the basis of that, the appearance of the lesion in the eye changes. So generally these are plateau shaped. It can be solitary, but generally they are not. They are multiple and may present bilaterally. So the thing regarding the color changes. So if the site is the breast or the lung carcinoma, which are the most common ones in cases of females and males correspondingly, so the lesion is yellowish white as I've shown here in the figure. In cases of cutaneous carcinoma, generally the lesions are brownish in color. In cases of a carcinoid tumor, a thyroid carcinoma or renal cell carcinoma, they are orangish in shape, orangish in color. So on the basis of color only, we can, locate the primary site of tumor. Just a gross idea, not a specific idea. And after that, progressing on to the other modes, on doing the B scan, we see a large choroidal mass, which shows a variable reflective pattern, which ranges from high to intermediate reflectivity. On doing the OCT scanning, we see a very lumpy, bumpy surface as is shown in the image with overlying fluid and neurosensory detachment. And again, the fundus fluorescein angiography in such cases again shows a peculiar pattern of late mottled hyperfluorescence as is shown in this image. Now coming on to another differential, which is a tubercular granuloma. Now to remember here that it generally occurs with a disseminated infection, and it is very difficult to find a tubercular granuloma without any sort of infection in the body. So, but in cases of a granuloma, we see a large yellowish subretinal mass, and the vitreous cells, they might or they might not be present. Generally, The study shows that they are absent. And on doing the B scan, we see a very large choroidal mass, which shows corresponding contact sign. So what is a contact sign? It is a localized adhesion between the choriocapillaries and the overlying RPE and neurosensory retina. And also the deeper layer shows hyperreflective dots, which again signify presence of inflammatory cells. And subretinal fluid can be there. On doing the B scan, we see a choroidal mass which shows low to moderate internal reflectivity. So this is the case which could be our diagnosis in this, our patient. But because of the age group and no systemic association, this diagnosis was excluded. So in the cases of idiopathic sclerocalcification, which is also known as the Bartter and Gitelman syndrome. So the Bartter and Gitelman syndromes are two syndromes, and they generally occur after the age group of 40 and above. The youngest age group in which this can occur is 40 to 45. And it presents with the similar pattern in which our patient presented, and it presents like a sclerocalcification, as can be seen in this OCT scan, that a calcified choroidal lesion is present here. And the B scan which I showed, again it shows that peculiar lesion with a pseudo-optic nerve head sign. The systemic associations present with the Bartter and Gitelman include the presence of hypercalciuria and hypocalciuria. And in the Bartter syndrome, generally there is some renal disorders associated, as it affects the loop of Henle and sodium uptake. So patient might also present with hypokalemia and hyponatremia also. In cases of Gitelman syndrome, the vitamin D levels are affected, and patient also has uric acid metabolism disturbances. So the patient presents with pseudo gout-like conditions also, and may also have carpopedal spasm or tetany. So this was the diagnosis. After excluding everything, we came to the final diagnosis of a choroidal osteoma. So the patient presented, as discussed before, with a sclerocalcified large lesion which involved the optic nerve and has presence of subretinal fluid, and it showed staining in the late fundus fluorescein images, and calcification was also seen over the disc, and this large hypointense lesion just juxtapapillary to it. And on B scan, it showed a calcified lesion with presence of a pseudo-optic nerve sign. And since the patient is young female and the lesion is unilateral, so therefore the diagnosis of choroidal osteoma was made. And this case is very rarely encountered, therefore making this case a very interesting one. So what could be the management options of this? So as regarding the choroidal osteoma per se, there is no standard treatment. Rather, the complications which occur due to the choroidal neovascularization or the subretinal fluid, they are treated. So we divide the treatment options among the two categories. In the first, the osteomas with the choroidal neovascularization, if the lesion is subfoveal, we go for transpupillary thermotherapy or photodynamic therapy, out of which photodynamic therapy is a preferred option. And we would also give intravitreal anti-VEGF injections, but this option is still under trial. For extrafoveal lesions, the photodynamic therapy or laser photocoagulation can be done, and intravitreal anti-VEGF injections could be given. For osteomas with presence of subretinal fluid, the light focal laser therapy can be done and is a preferred option. And over that, we see a transpupillary thermotherapy is done nowadays very commonly at majority places using a diode laser. And there are intravitreal anti-VEGF injections can again be given to reduce the presence of subretinal fluid, thus by avoiding the complications occurring because of it. Thank you.
So in your tubercular granuloma, so you maybe didn't mention that, on the surface, often you'll have especially in such large granulomas, often you'll have, chorioretinal anastomosis, and you'll have.
Yes, sir. Yes, sir. I didn't mention it here, sir.
Yeah. So,
Yes, sir.
commonly see those, blood vessels on the surface.
Yeah, right. Sir.
Yeah, so it's very common to see that. And it's kind of pathognomonic. Dr. Amod Gupta sir has described it that it's almost pathognomonic of TB granuloma to see those, anastomosis.
Yes, sir.
Retinochoroidal anastomosis. And so what my question to you is that, so in the SRF, you did mention the management. So with SRF, do you expect that with the longitudinal follow-up, this SRF can resolve spontaneously?
No, sir, not necessarily. It's not a rule that with one injection of anti-VEGF or with few injections that SRF goes away, because the main pathology that is occurring, it is, I think, below the level of the RP. Actually, the RP pumping system is affected. So even in our case, the osteoma case, again, the trial of anti-VEGF is going on. However, not very successful results have been obtained only with injecting intraorbital anti-VEGF. The laser is definitely needed there.
Right.
Because
so
with anti-VEGF, the fluid would go again, but the main pathology is not treated, so the fluid might again come back.
Yeah. So the thing is that although spontaneous resolution of SRF has been described, but what happens is that the tumor undergoes decalcification.
Right.
And when the tumor undergoes decalcification, the overlying, the retina and the RP, they undergo atrophy. Yeah. And so when it undergoes atrophy, the tumor changes. If you see in our case that at the edge, you are seeing that the yellow-white areas, those are the areas where, the decalcification is occurring,
Yes,
the bottom,
yes,
I mean, the infratemporal arcade, that area, whereas the central macular area is still orange-red, so that is the area which is still not decalcified.
Right.
Right.
Sir, right. Sir, right.
In this area that, the color changes from orange red to yellowish or light yellowish because of the atrophy of the overlying retina and RPE. And it is the atrophy of the overlying retina and RPE which is responsible for the RPE pump failure, and because of which subretinal fluid is very commonly seen in these tumors. And CNVM is not so common. Presence of SRF. I mean, overall, the CNVM is fairly common. About 50% cases will have CNVM. But, SRF does not necessarily mean that, most of the cases of SRF don't have CNVM. So the reason for SRF is decompensation or RP pump failure, because of which, SRF, is present in these cases. And anti-VEGFs have tried and, sometimes they work. And, and other modalities like you mentioned. So, that is what, so basic pathophysiology, if you understand, then it will be easy. And that is why, because of this decalcification, the margins are not very regular. As opposed to a corroidal hemangioma where the margins are very regular. In this, the margins are not very regular. Right?
Yes, sir.
So, yes. And any other pointers anybody would like to add, or any other comments? So what is the prognosis in these cases? Like, what is the visual prognosis?
So again, it depends whether the fovea is involved or not. Like in our patient, the lesion is encroaching fovea. However, some part of fovea is still, left out. So if the fovea is involved, so prognosis might not be that good. But however, like in our patient, the visual acuity was 6-9 parts, which is, I think, not that bad also. So if the patient gets treatment from the early process itself, so we might actually, help in saving her visual acuity.
Right. So I think that's rightly pointed out. And also, like you said in the start of your presentation, that it is definitely one of the most frequently misdiagnosed conditions for a general ophthalmologist. It has been, in the published literature that they say that about 90% of the times in a general ophthalmology clinic, this disease is missed or misdiagnosed.
Yeah. Yes, sir.
So
yes, sir.
It's a very important condition to keep in mind.
Right, sir.
Any other points, Dr. Shweta, Dr. Das?
Nothing, sir. Well presented.
Yes. So idiopathic sclerocorroidal calcification is
Yes.
when you have excluded some possible systemic associations. Some of which, like two of which are those Bartter and Gittelman syndrome. So other than that, there are some other systemic associations. Can you list those?
So, as I said, ma'am, there are many features like the metabolic alkalosis is affected there. So, the calciuria occurs, like hypercalciuria occurs in Barters, and hypocalciuria occurs in Gittelman. Apart from that, there might be carpopedal spasm or tetany can occur. And there are other syndromes like, so few features have been noticed by various scientists. There's one scientist known as Cohen, so he named it after this pseudo gout like features are there. So the syndrome is known as the Cohen syndrome. And yeah, so such systemic associations can be seen with the presence of idiopathic sclerocalcification.
Hyperparathyroidism.
Yeah. So the carpopedal spasm and tetany,
Yes.
that would correspond with hyperparathyroidism.
So basically, disorders of calcium and phosphorus metabolism have to be ruled out.
Yes, sir. Yes, sir.
Okay.
Anything else? Any other pointers or any comments, any questions, any queries from any of the participants?
I think Vijay presented really well, very comprehensively covered and well discussed. So all the same, if anybody else has any comments.
I think you should definitely follow up this patient, and if the patient comes back for anti-VEGF, that will be good because we'll have some follow up, and we can have some longitudinal follow up, and then definitely put it together as a case report because it's again not very common.
Right, sir. Rare. So the thing interesting about this is the rarity of this case.
Yes.
Not seen very often.
Right. So I think if there are no more questions, we can just end the meeting here.
Yes. Thank you so much, everybody. And I think Dr. Das has a birthday tomorrow, so we can wish him a happy birthday in advance.
Thank you, sir.
Birthday, sir.
Happy birthday.
Sir.
Happy birthday, sir.
Thanks in advance.
Yes.
Thank you.
But very good meeting today, and we should keep up the momentum. And I'll request, we can have journal clubs, and we can have some good case presentations, and some discussions also. So I think I was hoping that we can do half-an-hour sessions on Tuesdays and Fridays. Till we can't meet, we can do it on Zoom, and once we can meet, we can do it in the clinic itself, and we'll find a suitable time. So I think let's prepare for next week, Tuesday and Friday session. And I'll request maybe if Dr. Amrita or Dr. Tulsi are more prepared by Tuesday, we can have them or whoever is keen to present first.
Yes, sir.
Thank you.
Okay.
Thank you.
Okay. Thank you, sir.
Bye-bye. Thanks.
Bye, sir.
Good night, everybody. Thank you.